Ready? See the thumbs up in the back. There we go. All right, guys. Good afternoon. Thanks for having me. And we'll discuss different sports injuries. What I did is I kind of put together two different talks I have and put them, I don't know, does that sound like I'm reverberating? I don't know. I feel like an echo. It's coming back at me. It feels like there's an echo. I don't know if that's the hall or if it's just me. Do you guys sense it? All right, then I can deal with the ringing. All right. So I put together upper extremity and lower extremity talk for this because those are the most common things that I see. So we'll kind of just run through them, and if at the end, if we had time, we can talk about lots of things that you guys may want to talk about that I may not touch on here. Okay. So we'll start at the shoulder and work our way down. All right. Shoulder instability is common, but in the younger age group. All right. So typically, it's the person in their 20s, maybe their 30s. Once we get about past 40, this usually does not occur, all right? So generally, they're gonna have pain in the posterior or the back side of their shoulder, all right? Very, very common for this. It depends on the position of the arm, kind of like the pitchers, all right? When they sit there and they throw the ball like that, that's the vulnerable position for a shoulder to come out of socket. So they don't like doing that because it gives them pain. And then people talk about a dead arm syndrome, all right? So somebody throws a ball and all of a sudden it feels like their arm's dead, all right? It doesn't move. What happened was it came out of joint partly, stretches the nerves to the hand, and then you let it relax, goes back into socket fully, and then the nerves kind of subside and go away. All right, so that's pretty common. I don't see that very often, like I said, unless you're in your 20s, maybe the teens, all right? So treatment, almost always conservative 90% of the time. All right, exercise, physical therapy, medications, rarely injections, but you can make this better without surgery 9 out of 10 times. All right, if somebody gets what we call a Bankart lesion, let's say they dislocated completely because they had their arm up in football and their shoulder pops out, those people 9 out of 10 times need an operation. All right, so it depends on how you present. If you come in and this just has happened over time, like you're a swimmer, and the swimmer starts swimming and they get all of this and they get this little bit of instability, that you can fix non-surgically 90% of the time. If it's one event, a collision, it's more likely you cannot fix that. All right, so pretty big distinction on those two. Here, this is probably the most common thing that I see in my practice for shoulders. All right, this bursitis is probably the foundation that you really can't have any other shoulder issues unless you have bursitis on top of it. So that's the foundation. And then beyond that, you can have arthritis and rotator cuff tears and lots of other little things. So very common. Generally, once we get over 40, we start seeing this more commonly. All right, so we become less tolerant of this. Certainly, it's worse with overhead use. So you can do anything you want down here, you're good. But as soon as you do something overhead, it gets worse. All right, especially if you're lifting something heavy overhead, it makes it worse. The pain here is in the front, all right? So they generally get the pain up here or in the upper part of the arm. They don't get it really in the back. So they present with a different history, and that's pretty typical. I try to teach the residents and my PA that listen to your patient, they're telling you what's wrong, all right? They come in and say, my pain is up here. You got arthritis of their little joint up there. If it's here, it's most likely bursitis. If they're young and they start tapping the back of the shoulder, their shoulder's coming out of socket. Now you really all have to do is prove that that's actually what's happening. So what you guys tell in history is critical to help figure out which slot you really go into. Strength testing down in here, we test that because a lot of times you can just have bursitis, but you don't have a torn rotator cuff, all right? This tendon that moves your arm. And we'll talk about that a little bit. Now, on exam, this forward elevation impingement, which is this right here, this one right here, when you reach out to the side, all right, those two become pretty irritable. This one down here is usually the most irritable. This one most people tolerate pretty well because we can rotate your arm in a different way to make it raise. This one, if you do it this way, it's very irritating. If you raise your arm with your arm in this position, it's hard on you to do it, but if you raise your arm like this, it's much easier, all right? And it's all in how you rotate your anatomy about your shoulder. So how we do the exam helps determine what you told me about history, does it really make sense or not? All right. Now treatment for this. All right. There's the old cortisone shot that everybody hears about. And that's, by the time most people see me, they've already seen their primary care, they've done lots of things. So generally that is in my first sort of step when I see people, because they've had this problem going on for a long time and it hasn't gotten better. If it's the first time seeing you, generally you don't really do this sort of thing. You'll do that second or third. NSAIDs, all right, Aleve and Advil, all right, those are your primary drug. As long as you don't have ulcers or history of heartburn, indigestion, those are your go-to meds. My preferred one is Aleve for almost everything, all right? Not that Aleve is any better than ibuprofen, it just lasts longer. So it's a 12-hour drug versus a 6-hour drug. So it's much easier to take, and you will be more likely to take it twice a day instead of 4 times a day. One of the things I like to make sure you guys understand is when you take these medications, you want to take them regularly. And I see it every day. I saw it this morning. 3 people just been taking it here and there. And if you take a medicine like this here and there, it works here and there. You don't want it here and there. You want it to go away. So take it on schedule twice a day regularly for at least a week. And then if you got 80% of your problem to go away, great, you're on the right path. If you only got 50% of your problem to go away, don't stop yet. Keep taking it till you get to that number, all right? In a week, if it does not make any difference in your problem, well, then that's unusual, all right? Then we got to figure out why wouldn't you be getting better. Either we got to switch medications, maybe a shot, maybe therapy, but that's real important to understand how to use the drug. All right, so like I said, cortisone and Marcaine, those are really helpful. The diagnostic injections. A lady I saw this morning had her shoulder operated on in the military in 2000. They took out part of the bone in the top of her shoulder, but that's where her pain was. So she's in there telling me this, which means arthritis in that joint, but they took it out. They didn't excise it completely, all right? So I injected her 3 weeks ago. She came back and said for 2 days, she was perfect. She had no complaints in her shoulder. So the problem is this retained bony piece in her shoulder in this joint. And I said, she is still better, so you don't need treatment now, but when we get to it, I know exactly what to do, because the shot diagnosed it for me. Told me exactly what's going on in her shoulder. All right. So somebody who's confusing or has had previous surgery, the shots help diagnose you because they rule in certain things and they rule out certain things. All right. If we get the bursitis and we get the rotator cuff tears, 40, yeah, probably 50, much more common. Obviously, you get to 60, it's more common. Then it kind of drops off after that because arthritis becomes the biggest complaint, not so much the rotator cuff tear, all right? When people get this, they have identical symptoms to somebody with bursitis, but now they have some weakness when they try to use it, all right? And they'll notice that, and I'll be able to test that easily in the exam. They don't always have to have this because if the tear is relatively small, all right, they have the majority of their muscles still working and it keeps the strength up, but they get pain with it. And then they typically, in my hands, don't have a traumatic event. They'll just say it started 18 months ago, I've tried A, B, and C, I've relative rest, and it just hasn't gotten better, all right? So physical exam is pretty much the same as with that impingement or the bursitis. We do different tests to check the other muscles around the group, but the real definitive test when we get in here is going to be an MRI. I mean, everybody's familiar with what an MRI is now. It's a pretty common test and probably still one of the best tests I have for looking at the muscular and skeletal tissues around joints. It's a beautiful test on helping elucidate that. Our treatment is still the same as bursitis. NSAIDs are my number one choice. Relative rest, in other words, understanding what irritates it, all right, and avoiding that for now. And then cortisone shots, maybe. Not everyone needs surgery. As we get older, sometimes the tear is small, and they can overcome it by strength training what's remaining in the shoulder. All right, so you got to balance with the patient's health, their age, their problem, and put them all together and come up with a sensible solution. Okay, any questions on shoulder? Who's got shoulder problems? All right, I see it hurts to do that, doesn't it? All right, One of the things I see really commonly around the elbow, and you guys have heard of tennis elbow. That's probably the most common thing I'll see. And then there's golfer's elbow, which is the pain more on the inside. Tennis elbow is more out here, and the golfer's is on the inside. All right. So for me, where's the pain location? Is it on the inside or the outside? All right, that's pretty critical. This medial epicondylitis, this golfer's elbow, like I said, is on the inside in here, and people come in, you can touch it with your finger. They'll go, it's right there, and they'll point to one particular spot, and that's also true for tennis elbow. They start coming in, they point to their elbow, and then they'll just land, all right in this one spot. And it's really very tender, particularly if you have a heavy handshake or if you're trying to grip something heavy, and it's quite annoying. All right, treatment's very simple. Once you understand the problem, all right, bracing helps protect you. Cortisone shots do not fix this problem, all right, but they will make you feel better so you can fix it. So that's the whole purpose of the cortisone, is to take away that inflammation so your pain is better. Now you can go on to the exercise program, which actually fixes the problem in the tennis elbow or the golfer's elbow. So my biggest problem with that is if I do a shot on the shoulder or in the elbow, is the patients don't do the exercise program because they get better. They feel good, so they figure the problem is cured. And the problem's not cured. All I did was cover it up. And I covered it up so you can participate with the right exercise program to fix the problem. So they show up 5 to 7 months later and they go, it's back. All right, but they never went to therapy, they never did the exercise program, and never did it just because they said, no, it's better. So I try to harp on that a lot because I saw that, and I haven't seen it in years because I really tell people you got to do this, otherwise it's a Band-Aid, it doesn't fix your problem. All right. Now, down in the wrist, there's a tendonitis here that occurs right on the top. It kind of is in this area of your wrist. All right, and again, very focal. People come in and point to this one area. So if you play racket sports or you do anything of that nature, you can get this focal tendonitis, and it really is a driver for patients. They hate this thing. All right, it hurts every time they try to open their hand to grab a glass, or they try to touch the counter or the cabinet door. All those things really bother them, and they've come in droves for this as soon as they get it. It doesn't really go away easily. A leave doesn't work well for it because of the way it happens, and so they come in with a lot of complaints. This, down here, rest is okay, but injections will solve this problem 70% of the time, and surgery solves it 100% of the time, all right? I've tried all the other things and therapy, and nothing really works well. So it's either shot or surgery for this, and if you have this, you'll want that, all right, because it's that annoying. Carpal tunnel syndrome, very common. I'm sure you guys have all heard of this. It's been around for decades. Typically, my patients tell me that they wake up at night with their hand asleep. All right, they kind of shake their hand to wake it up. If they drive or read a book or a magazine, it also tends to go to sleep. Classically, it's in these 4 fingers, maybe these 3, and eventually, when it starts to disturb their sleep pattern, that's when they come in. If it doesn't disturb their sleep, they kind of blow it off and, oh yeah, it'll be fine, and leave it. But as soon as it wakes them up every night and then they don't sleep well, you don't have a good night, you have a bad day, they just go, I'm over it. Just fix it, make it go away, all right? Because this particular syndrome is a compression of the nerve, all right? And once you start getting symptoms for this, I'm not very tolerant of just bracing and therapy and doing things of that nature, because if you get nerve damage, you cannot fix nerve damage, all right? Once you get it, you can take the pressure off the nerve by surgery and halt any progress, but it doesn't mean that all of a sudden your nerve is going to heal with time. I saw a guy today, I did the carpal tunnel release on a year ago. His symptoms, so he's not waking up at night, all that, but he still gets tingling in his fingers. And I'm like, I can't fix the nerve. I didn't touch the nerve. All I did was take the pressure off your nerve. So I prevented future problems, and sometimes you heal those, but that's erratic, and I rather treat people the day before they got carpal tunnel, because then they never have nerve damage and problem is good. So his right hand is, we're going to go ahead and fix it because it hasn't gotten nerve damage yet, but I know he has the problem on that side. So that's an important point that I don't really delay when I see people with carpal tunnel. I'm like, you got it. It gets progressive and it gets worse with time. You ought to consider the release. We do it endoscopically, all right? So it's one small incision done in the wrist to release it, and most people are back at work Monday with the surgery on Thursday. So it's truly minor. It's definitely better than the open way that they used to do it, and you'll progress much quicker without the worries of damaging your nerve long term.
Can I ask you a quick
Sure.
question about that? My wife appeared to have all the classic symptoms, so her family practice doctor actually sent her to a neurologist, and it seemed kind of odd, but they did, she had all the signs and has this wristband and everything, and he did some type of nerve testing where he hooked her up to wires.
Correct.
And that came out that she didn't have it, but she still has all of the problems where, it's making her wake up at night, she gets the tingling, it's into certain fingers.
Right. And what he was talking about, his wife has these classic symptoms of this, but the nerve study test showed no nerve damage. Perfect candidate.
Okay.
The only reason that
Unfortunately, that was 2 years ago, so she may have nerve damage now.
maybe, but typically I'll see that the person's come in, they're waking up at night, but their nerve study tests are normal. And the only reason you can see anything on the nerve study test is when it shows there's nerve damage occurring.
That makes sense.
All right? If it's normal, if you're in this window where you're not really normal, but you're not damaging the nerve, you have the classic symptoms, but everything looks fine on the test. So you still have the diagnosis. It's just, hey, is it buggy enough to warrant the surgery yet? If it's normal, I don't really push them. I'm like, your nerve's fine, it's not damaged, you have the diagnosis. At some point in the future, whether it's 2 years, 2 months, pick your time and have it fixed. But there's no rush, all right?
Thank you.
All right, let's see. So we'll move down into the lower extremities, all right? Now, this trochanteric bursitis, it's very much in ladies more than men, all right? It's probably 99 or 100 to 1 that women get it over guys. Mainly because the pelvis in the female is made for childbearing, so the mechanics are different. And that's why ladies tend to get it. It's right at the outside part of your hip, so if it's right out in here, all right, and it can radiate down the leg and go up into the back or up on the top of the pelvis. So I don't think there's an hour in my day that goes by that I don't see this every hour, every time I'm in the office for the last 20 years. Very common, very easy to fix. The problem itself is this, what's called the ITB. It's a band that goes from here and runs all the way down to your knee. That's how come they can get this pain going into their knee itself. The simple stretching program, and that's why I kind of underscored it there, is what makes this go away. My wife still won't do it, but she likes to talk to me about it because she still won't do it as regular as I ask her to. It's probably the number one thing that will make it go away, but you have to do it regularly. And I don't mean 3 times a week. I mean on an hourly basis. Anytime, once you learn the stretches and you can do those, then you incorporate those into your lifestyle, whether you're watching a movie, reading the paper, a magazine, whatever it is, you can do these stretches in a sitting position. They're very easy to do. They actually feel good. It's kind of a good stretch when you do it. And a lot of ladies, you can get it on both sides, so you want to do it on both sides. Even though you may have one hip now, and the other hip's going to come on at some point. So you just keep your flexibility in, problem will disappear. Never had to operate on it. So it's very common and a very easy fix as well. And there it is right there, that guy right on the hip side. And probably saw 4 or 5 people just this morning. And again, they hover and they go right out to the right, straight dead to it. And then exam confirms what I'm expecting just by history and what they pointed to. Now, I threw this in. These are stress fractures, and I only throw it in because in the person who is, let's say, a runner or active, and they start getting groin pain, all right? This is something that you don't want to let sit, all right? So let's say you're running marathons, you want to start running, you pick up your running pace, and all of a sudden you're getting groin pain, all right? You run 5 miles into your 10-mile run, and at 6 miles, all of a sudden you get this groin pain that makes you stop. Then you start to walk, and it gets a little bit better, and then you start running 2 days later, same thing happens again. That's one of the hallmarks that you could be causing a fracture in the neck of your hip. And you really, this is one of the ones I tell my residents, you don't want to miss this, because if you complete this fracture, it's a life-changing event. all right? You're going to need your hip fixed or you're going to need your hip replaced. Something is going to happen, all right? And nothing good comes of it. So tell anybody in the audience, if you're active and you start noticing this groin pain and it comes on like I was saying, it's one of the ones you really want to be checked on to make sure you don't have this. If it's just pain, if you're laying in bed, it doesn't really happen like that. It's going to be with activity, all right? And you wonder how they find a lot of these? Military. Run, 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 run with your backs. And then they come and complain of pain, they go, keep running. All right? And then those guys complete their fracture, and it was disastrous on when they went back and studied them. All right? So it's really one of the ones that you want to heed and pay attention if you're in that category. All right. Now, more common, osteoarthritis in the hip. All right? You can see there's no space in this whatsoever. Let's go back one. Let's see. If you look up here, you can see a space between this bone and this bone here, that little dark stripe. You go down here, and that space is now gone. And that's typical for people with arthritis. Same groin pain. They end up with this pain in the groin, but it's not something that you can run 5 miles on and it occurs. It's almost a night pain, or if you just misstep, you get this pain. Your leg won't rotate quite as well, but very common, all right? It's definitely not as common as the bursitis I see, and people will come in and they'll point in here for arthritis, and they point out here for bursitis. They can cross over a little bit, but typically it's going to be more of those two areas what they talk about. And then x-rays help tell you which one it is, for sure. It's interesting, there was an article that came out about 2 months ago discussing knee arthritis and hip arthritis. And they find that knee arthritis is regenerative. In other words, it can heal itself some, all right? And I hadn't even thought about it in my practice till then, whereas I'll see knee patients for years, right? For years. I see her for years, and they get along okay. You can do shots here and there. Hips I don't see but once or twice, and they get their hip replaced. They do not have this regeneration capability in the cartilage in the hip for some reason, and they are different. And I don't see my hip arthritis patients that come in for 2 years' time or 4 years' time, and we just treat them along the course. They get their hip replaced in less than 4 months, just because their pain has gotten to that level. So it's pretty unusual that they last. Now, the medial collateral ligament in the knee. The knee is the most common joint that I see. It's the one that gets injured more than anything else I mentioned, all right? It's so involved as far as you're running and pivoting and cutting, and in collision sports, you can get hit kind of like this. They get hit towards the outside of the knee, and it strains the ligament on the inside because it tends to make it collapse inwards, all right? So you get this pain that sits on the inside of the knee, and it tends to come up right on the inside there. And the ligament's a long ligament, probably about 4 inches long there, and it occurs right there. We used to operate on it, all right, 20 years ago. I've only been here for 20, so before I was here, a lot of people ended up with surgery on this. We have realized that that's not the case, all right? These will heal, even if they're a little loose. They heal, and they do fine with no surgery at all right? So if you have other injuries, like an ACL we'll talk about, or something else, different story, but if you just have this isolated strain of this ligament, life's great. It'll heal, it'll be fine. It takes a couple months to make that happen. Now, who knows about ACLs? Anterior cruciate ligament, all right? Again, pretty common injury that I see. Very common, it's a non-contact, all right? So you're playing basketball, playing volleyball, field hockey, and all you do is you're cutting, you're pivoting, all right? And all of a sudden your knee kind of goes down on you. It aches, it swells pretty quickly, like an hour or two, all right? And then it doesn't feel stable. It can happen skiing, you know? So very rare do I see this from a contact injury. So the football player may be going through the line and he cuts, but he never gets hit and just goes down, all right? And that certainly is common for an ACL that can be torn. Not to go into all the lingo there, but you know, they end up with swelling, obviously pain. They lose motion because of this swelling. This is one of the tests that we do for it, which is very positive for it. And an MRI, again, helps me tell, did you tear that MCL2? Did you tear a meniscus or a cartilage? Did you bruise the bone? So there are all these other things that the MRI helps pick up, which will help decide the ultimate treatment for this. All right. Typically, without your ACL, you cannot really cut or pivot appropriately, all right? So if you went back to playing tennis or volleyball and you wanted to cut and pivot, the leg will not stay together. When you pivot, the knee will become dissociated and it'll rotate, all right? The term we use is pivot shift. So it'll pivot and then it shifts. And it just feels like it wants to give out on you, so you'll just avoid that. You'll stop playing the sports, you'll end up riding a bike or doing weight training and stuff that doesn't cause that sort of twisting event, and you can get by fine without it in that regard. Most of the people I see want to maintain their sports, and we end up doing reconstructions on those because 99 out of 100 don't do well going back to those sports without a reconstruction, okay? A guy I saw today, he's 29 and his has been torn since college, and he just got fed up with it. He was like, you know, I can't really do the things I want to do. It's been 9 years, and I can't get around and do any of the activities I want, and I'm going to get married here, and I'm going to have kids, and I just want my knee to be good. You know? So we're going to reconstruct his knee at this point in time. So kind of a classic thing that I see. So this is the ACL, and it's in the middle of your knee. Normally it connects all the way up here, all right? So this has been torn off, this bone up top. This is the same sort of knee, and this is a new ligament that now connects all the way to the back, all right? And we do it through all arthroscopic techniques now, all right? So you go home that same day, you can put weight on it right away, you can bend it right away. You start therapy within 3 to 4 days. The sooner we get you going, the sooner you get finished. The quickest I can get people back to sports in about 4 months, all right? The guy today had other tears, so his is going to be a 6-month return to sports. But that's a good trade-off for him because he really wants his knee better. All right. This is really another common one, kneecap pain, all right? And it's just anterior knee pain. People get pain in the front of their knee, particularly on stair climbing or squats, going up and down inclines, Nolan Trail, things of that nature. They'll see this, all right? And if they sit, all right, for a while, they may get a little stiffness in the front of their knee. They get up and take 5 or 10 steps, seems to work itself out and feels a little bit better. Typically, there's some mild arthritis behind the kneecap that's driving this sort of thing. And there are lots of little things you can do to try to improve it. I see it a lot more in my ladies than I do in my men, mainly because ladies don't have as much strength in their quad and their muscle up in the front of their leg as guys do. All right, so they got to work harder to get the strength that a guy has just because of the hormonal differences between guys and girls. All right, so that it is totally doable. It's just it takes a lot of work on the lady's part to gain that kind of strength. Let's see. Almost always we just do relative rest. In other words, I still want people active, but I want you understanding what the problem is. Again, another guy I saw today, this morning, and he's got this same issue. All right. He's in through the military. They operated on him in 05 with the scope. 06, they realigned his kneecap. And now they just want to give him pain medicine and treat him like that. And I was like, well, I don't give you pain medicine. You don't need pain medicine for this. You need to understand your problem. You need to understand what I call the biomechanics of this kneecap. And then once you understand it, you have to apply it to your everyday life. All right? You have to really appreciate it. And I mentioned, like if you were to go up steps 2 at a time, that is worse for your knee. And he goes, I always do that. And I'm like, he goes, it aches, but I just put up with it. I go, no, you don't want to do that. You want to get the right exercise. You want to go up 1 at a time. And so nobody took the time to say, you got to figure this out. If you understand your problem, and once you understand it and you can apply it to the real world, kind of like learning math principles, all right, once you get them, you can do pretty much any math equation out there. Same with him. So I'm almost like, you're in therapy, you need medication, but not a narcotic, and you got to get an understanding of the problem going on. And I can't make him normal, but I certainly can make him better than what he is. All right, so it really is for me, I got to get you guys to understand this problem mechanically and then apply it to your everyday scenarios. Very rare do I ever operate on this, once every 3 years, you know, pretty darn rare. Meniscus tears, definitely the most common injury that I see in the knee. And people talk about it as a cartilage, all right? And a cartilage is the common term I hear out there for this. And people will pivot or shift, or they'll just say, I just started aching on me 6 weeks ago. It hurts either on the inside of my knee or the outside. Very common, the inside is what drives this. And they notice that it may be swelling on them, It may buckle, all right, this word there, where they feel like it kind of gives out a little bit, and they just don't trust it as well, all right? So if I get an x-ray, you have these symptoms and you get an x-ray and the x-ray looks pretty normal, so it's really not arthritis, almost always it's going to be this, all right? Very, very common on that. Generally, it needs surgery to recover, all right? Once it's torn, there is no blood supply in the meniscus, therefore it can never heal. It just sits there, all right? And it will get bigger with time. So if somebody has this, we know it, and they go, well, I'm okay with it. I'm like, that's okay. Live with it. It's all right. But when it starts to bother you enough, the only way to fix that is to surgically correct it. Now, there's another one I see, not as common, and this is jumper's knee. You might have seen guys wearing a little strap around their knee when they play certain sports. Typically, it's going to be volleyball or basketball. Those sort of jumping activities are what tends to drive this, all right? Typically, you get pain just below the kneecap. Like with the kneecap pain, the pain is actually on the kneecap. And if somebody comes in with this, you touch their kneecap and it's fine, but you go just an inch below the kneecap, the bony part of that, and touch, and you'll find it, and again, it's in one small area, and as you palpate it, it's generally right in the midline, right below the bony kneecap. And they'll get this, a lot of pain with it. Typically, stretch, ice usually helps. Those non-steroids, again, which are okay for this. I always try it, but a lot of times they do not work for this problem because the tendon doesn't have a good blood supply. It's got to have blood, otherwise the medicine never gets there, all right? Bracing is okay. It's about 50-50. And then typically therapy really can make, again, 9 out of 10 of these guys better without any surgery. I don't think I've operated on this in 3 or 4 years. It's been a long time. Again, once you understand the problem and you get to the understanding of that, and then you do the right exercises without irritating the problem, you can make the problem go away. All right? So it's really back to getting you guys to have the same level of understanding that I do of this in order to apply it to your routine. And there it is down here, right at the very bottom of the kneecap. All right. And then ankle sprains. Again, everybody has these, all right? Absolutely, no, I can't believe anybody doesn't have an ankle sprain. That's amazing to me if you don't. The most common thing that I see is that if you have an ankle sprain, you may go to an urgent care, they put you in a splint, all right, ice it, and then you stay in the splint for days and don't move your ankle. Wrong answer, all right? The rehab will be extended 5 times longer if you do that. So what you want to do is you can see an urgent care or you can come to the practice. Once the x-ray shows you do not have a fracture, all right, you want to move this. You want to start range of motion and stretching immediately. And it has been shown to quicken rehab up to 5 times faster than normal, all right, because you've got to get full flexibility back in your ankle to make it stable again. I've seen people 10 months out from an ankle sprain and they're wondering why they're not getting better. They just never achieve full range of motion. Again, it's an understanding going, okay, this is what you want to do, but I mean, my left ankle dislocates. It doesn't even sprain anymore. It just comes out 90 degrees off, all right? And generally, in about a week, I'm good at walking normally again and I can play volleyball again and life's fine, all right? But I start stretching it immediately. I don't stop playing. I keep playing, all right? Because that movement on the court helps me keep my flexibility still. Yeah, it swells and aches and everything else, and I'll add the Aleve in when I need it, but I keep moving it. I don't rest it at all because it just causes me longer rehab, and that's not my plan. All right, so that's real important to know that you want to make sure your Achilles doesn't get tight and you start stretching that. All right, that's really critical. And this one, I see it occasionally, and this is again in the 40 to 50-year-old guy, and they tend to be playing basketball. And I think that's got to be 90% of the history I hear about this. And they're playing and they'll feel like they're on the court and it feels like somebody kicked them. And they turn around and there's nobody there. And they'll go, you know, the ball hit them or something, and then that's what's happened is they've ruptured this Achilles. This tendon has been ruptured in the mid portion. So then they come in, you'll see swelling, and then you'll be able to touch the tendon. And if you feel your tendon now, it's a rigid structure all the way down. You'll go along it, all of a sudden you drop into a little hole, and you come back to the tendon again. And that pretty much confirms the diagnosis just by that. But almost always they feel like they got shot or kicked. You know, that's a pretty common statement that they'll tell me. Generally, surgery is really the best answer for that because the tendon disrupts and distracts. All right, so you want to put it back together to get the optimum strength to be able to play those sports again. I can't remember the last time that I didn't operate on this just because of the functional outcome that occurs if you don't do it. They just don't have, they're weak on their jump and they're weak on their activities. And that's the little tendon tear right there. All right, guys, open house. Got any questions? There's a lot of information about a bunch of different little things, but those are the highlights of the different joints that I see from sports injuries over the years. Oh, come on. Okay.
What do you recommend for somebody who can't take a lot of the
Yeah, and if you can't take it, is it indigestion or something that does that, or what?
Yeah, I can take it once or twice, but if I try to take it for a week or 2 weeks, then
Yeah, and if somebody's tried it and you've tried the Aleve and it gives you indigestion or heartburn, they make prescription agents now that are made for those people. All right, so if you've tried the Aleve or you can't really tolerate it, then I put them on the prescription strength and say, okay, take it with food or milk, try this one and see if that works any better. If it still gives you indigestion, then I tend to back away from those and we go in different avenues. I'm not here to create problems. Oh, yeah.
20 years ago, you only heard about ankle sprains, and nowadays, particularly with professional athletes, you hear like high ankle sprains. And they always say, well, that's going to take longer. Functionally, what's the difference?
A high ankle
sprain and a high ankle.
Right, a high ankle sprain is exactly what they say. Instead of spraining down around the ankle, you sprain the ligament between the two bones, probably about 2 inches above where you normally would sprain, all right? And it's a different mechanism. It's typically when you sprain an ankle, you're jumping and you're coming down, your toes pointed. You do this and you roll it over. That's pretty classic. If your foot's like this and you sprain like that, it pops these different ligaments. So those people I know take twice as long to get better as the person who has a common ankle sprain. So we see them, but again, maybe 1 in 100, not very common. And they just come with a different swelling in a different area. Any more questions? Yeah.
Example based on your feet, like plantar fasciitis, is that like in the sports?
I don't see it as much in sports. It's more as you age, you lose the normal cushion underneath the heel. And then typically the scenario is you lose the cushion of the heel and your weight goes up, all right? And it eventually is going to throw it over where there's too much pressure in the heel, all right? The fixes for it are you'll get new shoes, you'll put in inserts in the shoes to recreate that cushion, and then on the hard side is losing the weight, all right? So you get the seesaw to flip back down the correct position again. For plantar fasciitis, I've not found one thing that works great. There's probably about 10 things that all work a little bit, and if you do them all together, life's pretty good. So there's a brace, there's icing, there's medications, there's the stretches, there's the weight loss, there's the shoes, there's the insert, and you add all these together and life's not bad. But I just like shooting one arrow at something and fixing it, not for that problem. It takes the concerted effort of multiple different interventions to try to make you whole again. Yeah.
Can you repair a rotator cuff tear by yourself, or does that really require surgery? I don't know if that's one of those areas that it just won't get better.
Right, and it tears because the blood supply to that area is very minimal. So if you get one tear in it, it never heals, so it hangs out. So you may tear it when you're 35 a little bit, or you just wear and tear it by playing tennis, and then it's not like it happens overnight, but it seems like that because all of a sudden it'll be at a rate where, like the straw that breaks the camel's back. Eventually it gets to the point where it's like, gosh, why is that aching so much? And then your tear becomes big enough that it's symptomatic for you. All right, kind of like tires on the car, they wear, and eventually that tire will pop. All right, and you'll go, but I didn't hit anything. All right, it just wore enough that it happened. So we're all ticking time bombs. I figured you got to play smarter, not harder. Any other questions?
I have one.
Yeah.
For young boys and girls who play soccer, ages 10 to 14,
Yeah.
what's the best remedy for those kids that complain of like heel issues on the growth plate kind of thing?
Yeah.
I've got players that complain about that all the time. We've tried
Put them in goalie. No, I mean, I coach middle school soccer, and a couple of the guys on my team have what's called Seaver's disease, and it's a growth plate problem in the back of the heel. And I have them take their leave before we play, and if it starts taking on them, I'll stick them in goalie for a quarter, all right, because we play quarters to rotate everybody evenly, and there's not a fix for it. There's none. You can ice when you get done with practice, stretch out well normally. If it bothers them during game, you got to back off a little bit. And full cycle takes about 2 years for it to go away from start to finish. So it all goes away. Everybody's pain of that will disappear completely once their growth is finished. So you just got to kind of tolerate it for now. Everybody hates goalie, so they don't want to tell me about it. Any other questions? Well, thanks for having me, guys. Oh, not you.
I'm sorry. Well, as long as you're here.
Okay.
I went to a little seminar on knee replacements the other day, and they said after knee replacement, you don't have an ACL.
That is correct.
Does the knee take, because you told me I could play volleyball afterwards.
Yep.
I played volleyball before.
Yep.
I obviously couldn't move age.
Yep.
So the knee takes that, bears that.
When knee replacements are designed, they're designed to accommodate for no ACL. So they're designed with more stability to recreate that through a different way. So mechanically, when you take that out, the knee is designed to make up for that. So that's why you can still do it. Yes?
So do you have to get an ACL repair? Or can you just?
No. I don't talk anybody into anything. All right? No, and it's purely elective. I look at myself, I have knowledge, I give you the knowledge, and you make a decision. You know, it's, hey, you could do it, you can wait. I mean, the guy today, he's been trying, and it just to the point where he's like, I'm over it. I'm just need to get it fixed. If somebody says I got an ACL tear, but it's not so bad, and all I want to do is ride my bike and walk to work, okay, well, let's just wait and see how you do. All right, so it really depends on the person. Most of the people I see want to remain active and don't want to give that part up. So no, there's not much that I tell people they ought to have done. It's more a decision on their part once I impart whatever information they'd like to know. Any other?
Okay, one more.
Yeah.
As long as you gotta pull the screw out, the bone just grows into that place, area, how long does that take?
6 weeks. You want to keep the screw?
An old person?
Do you want to keep the screw? It's kind of cool. You can like put it in your wood door frame. Yeah.
Thank you.
All right. Yes.
You get shots, how often do you get the shot?
Max is every 3 months. So 4 times a year. And that was it. Cortisone shots and anything, max is every 3 months. All right. If somebody's getting them every 3 months, then either I'm not real happy or something's going on, or if they have end-stage arthritis, you're not going to do any harm. You know, it's like, hey, as long as they're happy with it, I'm okay with it. But if you're injecting an Achilles tendonitis or a deep veins or a carpal tunnel, nah, that's not the right answer. You should fix the problem and move on. All right. Thanks again, guys. Appreciate you having me.